Hello all, welcome to AETCM EM Rapid 2023. The last few weeks we have been uploading frequent videos. The must-know topic for EM exam-going residents. So that is what EM Rapid is all about. I am here to deal one of the most important topic regarding snake bite or Ophitoxemia. That's what we are going to discuss maybe in the next 20 to 30 minutes. See, there are various lectures on snake bite already available in our YouTube channel. There is also a panel discussion on this. So what I am going to do is I am just going to run through these slides and we are just going to have a quick revision of the management of snake bite. For the next 20 minutes, that's what we are going to do. So coming to the introduction, I'll just go through briefly what are the major components that you should remember regarding whenever you deal with a snake bite and venomation. What are the common things that you need to remember? What are the common snakes that are venomous in and around India? So that is the next thing. That is a big four, and now it's time to say the big five. And what is the composition of the snake venom? What are the clinical features? How will be the syndromic approach that the patient will present to the ED? And what all things you should do, what all things you should not do, and basic management including anti-snake venom administration. So that is what we are going to discuss maybe in the next 20-30 minutes. So this is just an overview. There is approximately 64,000 death due to snake bite in India, and India accounts for almost 80% of the global snake biters. So that is one of the alarming statistics that you see here. This is as well as the 2019 updates. So these are the areas where you can see whether there is maximum number of snake bites in India. So when you look at the map, whatever has been shown, see the number of death that is happening due to snake bite in various part of India. So this is the representation of that, and this is again you can see the graphical representation. It's a district-wise prevalence of snake envenomation, and what are the common species that has been involved in this death. So as we say, what are the common snakes that is venomous in and around India? We can say that the most important, you can remember it as cobra, that is Naja, the Indian cobra, Indian spectacle cobra. Then you have the Russell's viper, saw-scale viper, and you have the common crate. So these are the one, and we have in the Malabar region towards that area, there is a lot of Malabar pit viper, and also there is Humnose pit viper, which is the pit viper family itself causing to an amount of envenomation in India. So that is the major snakes. So this is again the pictorial representation. The common cobra, the Naja. You have to remember the venom is primarily neurotoxin. Then you have the common crate, Bungarus ceruleus. Again, these are two Elapidae family. So again, the venom is neurotoxin, and you have the Viperidae family where you have saw-scale viper and Russell's viper. Saw-scale viper is otherwise Echinus carinatus. Venom is hemotoxic, and you have the Russell's viper, that is Daboia russellii. And you can remember one thing, it is both hemotoxic as well as neurotoxic. So that is one additional thing that you can remember. So Russell's viper has got both hemotoxic and neurotoxic envenomation features. So now quickly, what I told is some of the, it's time to say the big five. So we can call it as Humnose pit viper, Hypnale. So that is what is Humnose pit viper. This is basically seen in Kerala, Karnataka, and Maharashtra, Goa, and Tamil Nadu. Venom mainly causes the renal failure. So that is the most important culprit, and it is also amounting to big five. So today we can say it as big five. So a lot of case reports has been coming with Hypnale. Now, what is the major composition of this venom? Just for your understanding, so 90% of these things are protein. So there are enzymes, hydrolysis, hyaluronidase, zinc metalloproteinase, which damage the endothelium. There is procoagulant, which causes the DIC part. There is phospholipase A2, which is basically a sedative. There is postsynaptic alpha neurotoxin, which bind with the acetylcholinergic receptor, and also there is a presynaptic beta neurotoxin, which damages the nerve ending. So basically, the snake venom, as you know, the snake venomation we can divide into two. You can have venomous snake bites, among that hemotoxic and neurotoxic, and a combination of hemotoxic and neurotoxic. When we discuss regarding hemotoxicity, the major problem that causes is majority of the time it is bleeding disorder, and it can cause coagulation. Otherwise, the coagulation disorders also, the major time it causes is the bleeding disorders, and it can also have coagulopathy, clotting related issues also can be seen, but it's a less number only. And when you come to neurotoxicity, again the problem can start with the respiratory failure, and you can have the classical broken neck sign. We'll go through the pictorial representation, and in very few group of patients, both neurotoxicity and hemotoxicity, that is most commonly when you see with Daboyer Raselli, that is Russell's viper and venomation. So snake venom, it is variation is based on geography. Snake do not exhaust their entire source of venom. Even after several strike, there will be still they will have amount of venom that is enough. Both adult and child victim may require the same amount of anti-snake venom. So that is the one important thing when we are treating in a child. So in basically when we have child dosings for all the drugs, but here when you want to give anti-venom, you need to give full dose, just like for the adult, how much you are planning to give, you need to give the full dose of anti-snake venom that we will discuss. Although large snakes tend to inject more venom than smaller specimens of the same species, but younger viper may be richer in some dangerous components. So that might be more than enough to cause a death. And also there is a concept called as dry bite, either because of mechanical insufficiency or snake's control of venom discharge. Every bite need not have a venom injected onto the patient. So there can be a possibility of dry bite. Around 30% of the bites can be of dry bite. So that is the statistical significance of that. And now coming to the clinical effects of snake venom, as I told, you can remember three things. One is local symptoms, you can have systemic symptoms, and in systemic symptoms, as I told, you can have three: chemotoxicity, neurotoxicity, and hemotoxicity and neurotoxicity. So you can have local signs plus systemic signs. In some patients, you will just have local, some patients you will have systemic as well as local, and in some group only systemic. So that's what we are going to discuss in the next few slides. So local symptoms, the most important thing is the fang mark, may not be seen in crate bite, so that keep that in mind. And there can be local pain and bleeding, local inflammatory signs, blistering, lymphangitis, lymph node enlargement, which is one of the most important clinical features that you need to look is for the localized lymphadenopathy, because that is one of the indications to start your anti-snake venom. Then you can look for the abscess formation, necrosis, and compartment syndrome. So these are the things that you need to remember. Now coming to the bite mark, these are the certain pictorial representation. You just see the venomous snake. So it is poison. It is, you have to name it as venomous snake. So these are the fangs that you are able to see in here. And when you see non-venomous, there will not be fang mark. So the bite mark, exactly the fang mark will look something like a 2 dots. So approximately 0.5 centimeter apart. So that is how a fang mark will look like. But when you look at this, these are looking like a scratch mark. So this is again, you can see the fangs of a spectacle cobra, Russell's viper, common crate. You see the common crate is very tiny. So that is the reason why you don't get any local reaction when you are dealing with a patient with common crate envenomation. Then you see the saw scale viper. So it has got little bit larger one. You are see Russell's viper very large. Cobra also you are able to see large. But when you see the common crate, it is very small. So that is very small, like an hypodermic needle. So you will not be able to appreciate a fang mark in a patient with crate envenomation, fang mark. So in real life, it is not that simple. So as I told, you can just see this thing. You doesn't feel like an fang mark, looks like just like a scratch mark, but it was being caused by a spectacle cobra. So that is again very important. So even you can have a single bite mark, so that you can see in Russell's viper. So the most important thing, the local signs and symptom is not sufficient enough. You need to always do the clinical examination and require blood investigation for diagnosing of your features of snake envenomation. So this is again the small scratch mark that you are able to see in here. So this is again severe local symptom. You can see the blistering, the blood formation, and the erythema, and the blackish discoloration, and all those things you are able to appreciate in that image. Now coming to the systemic symptoms. So we discussed regarding the local symptoms. Now what are the common systemic symptoms? Always remember, one of the commonest symptoms that you can have is vomiting and abdominal pain, especially with crate envenomation. So initially to start off with, as I told before, you can have bleeding tendency, most commonly with Vibridae species. Then you have ptosis, ophthalmoplegia, and neurological weakness that is seen in Elapidae and Russell's viper. And you have myalgia, stiffness, tenderness, trismus, and myoglobinuria, which we can see in sea snake. Renal failure, Humnose, Spit viper, and saw scale viper. Pituitary and adrenal insufficiency, very common with Russell's viper. DIC and bleeding plus thrombosis, it's seen again in viper. And hypotension bar shock, which is very important. There can be many reasons for why you are having an hypotension in a snake envenomation. The most common things that you need to remember is that the hypotension, it can be The first reason for hypotension, it can be due to sudden anxiety, and it can be just a vasovagal syncope due to the snake envenomation. The second thing, it can be a myocarditis. It can be the toxin can directly affect your conduction system and can have myocarditis resulting in hypotension and all those things. Third thing, it can be due to the anaphylaxis of the ASV what you are administering. So anaphylaxis to your anti-snake venom that you are administering. So that will be the other reason that you need to remember. And fourth one, it can be due to bleeding manifestation. Lot of hemorrhagic shock the patient has gone in, but it is very, very unlikely. And fifth one, it can be hypotension due to sepsis and septic shock, because of the affected limb has gone into the sepsis, and further the patient can have septic shock. And just like in Sheehan syndrome, this patient with hemotoxic envenomation, they can bleed into the adrenal, so adrenal hemorrhage. So that is another reason for hypotension. So whenever you see a hypotension in a patient with snake envenomation, you keep these things in your mind. It can be a simple anxiety vasovagal syncope. It can be due to the direct cardiotoxin effect. It can be to the anaphylaxis to your anti-snake venom. It can be due to the bleeding, sepsis, septic shock, and adrenal hemorrhage that is commonly seen in hemotoxic envenomation. So our idea here is to see when the patient come to the emergency room, you need to recognize that this patient has require anti-snake venom, or whether there is any features of envenomation is there or not. That will be our idea behind this. So what we need to do in here, we need to have a syndromic approach for a patient that is coming to the emergency room. So let's see what is the syndromic approach. So we have syndrome number 1, where you got bleeding and clotting manifestation. There is a local swelling. So what do you need to suspect? So Viperidae, all species. So all species of Viperidae, that is here Soskill viper, Russell's viper, and your hum nose, they can just come with local bleeding and local swelling. So just keep in mind Viperidae species. So that is a syndrome number 1. So next go to the syndrome number 2. There is bleeding by clotting, there is local swelling, there is renal failure, and there is evidence of shock. So most commonly by Russell's viper, but also keep in mind it can be due to your hum nose pit viper. So snake identification, as I told, it is not very important. But if you are able to recognize, well and good, but snake identification is not very important. But what we need to do is this syndromic approach, and you need to recognize whether it is a Russell's viper or whether it's generally a Viperidae family, or whether it is caused by an Elapidae family. So that is what is this syndromic approach is what we are discussing right now. And again, we have the same syndrome, that is you have bleeding disorder, you have local swelling, you have renal failure, and you have shock, plus evidence of neurotoxic envenomation, plus ptosis, external ophthalmoplegia, facial weakness, remember Russell's viper. So whenever you have a combination of neurotoxic and hemotoxic, remember that it can be due to your Russell's viper. So again, as I told, acute pituitary insufficiency, again hemotoxics, Russell's viper is very, very notorious to cause that. Now coming to the third syndrome, you have local envenomation features, you have features of neurotoxicity as evident by ptosis, external ophthalmoplegia, and facial weakness. Remember, it can be cobra or king cobra. So that is what syndrome number 3. So there is local features with neurotoxic features. It can be cobra or king cobra. And the next is the syndrome 4. You are getting a neurotoxic features. You are having ptosis, external ophthalmoplegia, paralysis and all, but there is no local swelling. As I told, there will not be any local reaction or fang marks available. So bitten on land while sleeping, that is a classical history. With abdominal pain or without abdominal pain, always consider common trait. So that can be the syndrome 4 that you need to remember. So remember that without local sign, they are having neurological features. You need to think in terms of a syndrome 4, that is the crate envenomation. Then you have syndrome 4, where you are having no local, absent fang marks, plus abdominal pain, bitten in the sea. You remember that it is a sea snake. Also there can be evidence of paralysis. So these are the syndromes that you need to remember. So whenever the patient is coming to the ED, you analyze them and you just see where we can place them as the syndromic approach. Whether it is just local signs with neurological, okay, I am dealing with a cobra. There is no local signs with neurological, okay, I am dealing with a common crate. Whether there is local sign, bleeding manifestation, as well as renal failure, you think, okay, I am dealing with a Viperidae family. So that is what you need to remember. Without snake identification, just with the clinical features, we can come to conclusion which is a possible snake has bitten him and what is the syndrome. And even if you are recognizing any of these things, you are going to deal with anti-snake venom, which is a polyvalent anti-snake venom, what is available. So whether it is cobra or whether it is crate or whether it is the, but there will be certain changes in the management. But in general, the main antidote is here anti-snake venom for your neutralizing agent. So again, finally, you can, if it is bitten on the sea, it is sea snake. When it is bitten on the land, that is renal failure, paralysis, and dark brown urine, that is myoglobinuria. Basically, you need to remember Russell's viper. So these are the major 5 syndromes that we have discussed now. This is just a flowchart of whatever we have discussed. So whether there is local swelling or non-local swelling, features of neurotoxicity with hemotoxicity, only hemotoxicity, no local signs. This is the same flowchart with whatever syndrome we have discussed. This is the WHO guidelines what we are discussing. So you can just go through this flowchart for your quick reference. Now there is some entity called as cobra spit ophthalmia, which you did not do any need of anti-snake venom. It can cause intense pain, profuse watering with whitish discharge, and you can have a congested conjunctiva, spasm of swelling of the eyelid. You just need to have a thorough washing of the thing. That is more than enough. Now coming to the important stages of management. So the most important stage of management were why the patient dies. So that is the most important. Most importantly, improper first aid, and they are not taking to a proper center where there is an anti-snake venom availability. So that is the most important. You need to give a proper first aid and do not take to a center where they claim to have some alternative treatment therapy, whether they are going to save the patient. Don't do that. Take the patient to a center where there is an anti-snake venom facility availability. So transportation to the hospital, rapid clinical assessment and resuscitation, and detailed clinical assessment for whatever we have discussed, and what are the basic investigations that you require, and most importantly anti-venom treatment, and you have to look for, observe the patient for the requirement of further doses of anti-venom. So we'll just go through those, discuss that. And supportive and ancillary treatment, that is again very important, and treatment of the bitten part, rehabilitation, treatment of chronic complication, and advising how to avoid further bite. Suppose you think that he has been a high risk individual, he is going to get snake bite then and there itself. So avoid how to, advising on how to avoid this future snake bites also, you need to see that. So what are the aims of first aid? So the most important thing that you can remember, reassure the snake bite victim, attempt to delay systemic absorption of venom. That is our idea. So preserve life and prevent complication before patient can receive medical care at a hospital. Control distressing or dangerously early symptoms of envenomation. So you need to recognize and you need to treat. Arrange the transport to a place where they can receive the medical care. Very, very important. Where they have anti-snake venom facility. Above all, do no harm. So that is the primum non nocere, what we have all learned. Do not attempt to kill it, as it may be dangerous. Don't go behind the snake. So as I told, snake bite identification is not at all priority. Maybe you can take a picture in your photo for the mobile phone if you have, but routinely we doesn't need that. Reassure the victim who may be very anxious. Immobilize the bitten limb. So that is how, what you need to remember. Do it right. Do it right. So what is do it right? So do not cut or squeeze or do anything. So what you need to remember, do it right, reassure the victim, immobilize the bitten limb, get to hospital and tell the doctor regarding the symptoms of what all things have happened and all. So that is do it right. So this is what you can do, some pressure pad immobilization, and do not ever use a tourniquet. You can do something like a pressure immobilization. Already there is a video available on that. You can check that video. So these are the different methods by which most traditional first aid measures should be discouraged, and they do more harm than good. So avoid any interference with the wound, and no tourniquet. I am just slashing off, no usage of tourniquet. That should not be helped. See the effect of tourniquet. This should not be done. This should not be done. Just remember, these things are obsolete, and you should not practice putting a tourniquet. So this is what happened to a limb after the use of tourniquet. So no more tourniquet. And what will you do? Already there is a tourniquet in place. So what you can do, the best thing what you can do is that when there is already tourniquet in place, what you can just keep our normal BP cuff above this thing and just keep the pressure above the systolic pressure and release the tourniquet, and slowly you release the BP cuff. So that sudden release of tourniquet will not have a rapid entry of venom into circulation if the patient has been bitten by a venomous snake. So coming to the management aspect as such, so the rapid primary clinical assessment and resuscitation is the key. So airway, breathing, circulation holds good. ABCD approach is the same. So airway, breathing issue, circulation, disability, especially the patient can have respiratory paralysis and exposure and environment control again. So that is the basic ABCD approach. So what are the investigations that you need to do? So we'll just go back to the situation. The patient has been brought into the hospital and proper first aid has been given to the patient, and you have rapidly assessed the vital signs, and there is something that you can do is a single breath count. So what is single breath count? You need to ask the patient to take a deep breath and count from 1 to 30. Usually everyone will be able to do that, and you make a watch of it. So after the 20 minutes you again repeat this uh, single breath count. If initially it was something like 35, 40, now it is only 20. So there is a significant dip. The patient is going for a respiratory failure. So that is a simple thing that you can do at the bedside, which can help you if the patient is going for a respiratory failure or not. So other investigation that you need to do is something called as 20 minutes whole blood clotting time. That is what is being recommended. But remember that this is for peripheral hospitals where you don't have facilities for other coagulation profile investigation. Suppose you are in a peripheral center where you don't have anything. What you can have, there is a lot of snake elimination coming into your center. What you need to do, keep a fresh sample of blood in a clean glass container. So before that, you need to have a clean glass container. You should not be going around during the time of patient when coming to find out a glass container. It should be clean and kept it dry. So you need to prepare before itself when you are going to get a patient. So then you take a clean glass container, keep a freshly prepared blood of around 2 ml, and you keep it undisturbed for 20 minutes. Undisturbed for 20 minutes, no shaking, nothing, and undisturbed for 20 minutes, and you see whether the blood has clotted or not. If the blood has clotted, you can say that 20 minutes WBCT is negative. If blood has not clotted, it is positive. So that is one sign that the patient has gone into disseminated intravascular coagulation. So that is one investigation that you can do at the bedside. And other investigation that you need, the most important one will be a PT-INR, where PT-INR is the one of the most early marker. Like when you see WBCT, it will take 50% of your coagulation factors to get deranged. But when you send a PT-INR, even 20% of the clotting factors that is deranged, it will start increasing. So one investigation that you can do is PT-INR. So you can look in for the hemotoxic features. Then other investigation, what you need will be a complete blood count. So that is again, you have to look for decrease in the platelet count. So that is CBC, and also you can look for a peripheral blood smear, whether there is any evidence of hemolysis, maybe a venous blood gas. You can look in for any evidence of acidosis and renal failure, RFT, electrolytes, and urine routine. Among electrolytes, the most important electrolyte will be potassium. So these are the basic investigation that you might be able need to send when a patient is getting admitted to you. So remember, when you don't have facility, you can go for your 20 minutes WBCT. But when you have a facility to do PT-INR, get those PT-INR, and no point of care PT-INR, no POCT INR, because it has been found that there has been some issues with POCT INR in snake envenomation. There has been some Australian studies. So it is recommended not to use a point of care PT-INR for snake envenomation. You can always send a lab. Maybe in the future generation to come, this concept will also change. But right now, no point of care INR for snake envenomation. You can do it in the lab. And these are the other investigations that you need to order when you have a patient with snake envenomation. So coming to the indication of ASV. So that is again one important thing. Just quickly before that, I'll just say what is an ASV. ASV is basically an polyvalent anti-snake venom. So that is what is ASV. So it is basically covers big four, that is the common cobra, Indian cobra, common crate, Russell's viper, and saw scale viper. So only 4 of this venom will be neutralized with the anti-snake venom. So whenever you have a patient with you have decided to give administered anti-snake venom, you have decided, okay, I wanted to give anti-snake venom to this patient. What are decisions, key decisions you need to decide? Okay, what are the indications? What are the basic indications to give your anti-snake venom? So the most common indication will be a fang mark with fast spreading local swelling with tender nodes. So that is one of the earliest indication, local sign. And hemostatic abnormality, either 20 minutes WBCT or PT-INR becoming positive. And you have features of neurotoxicity like ptosis ophthalmoplegia, hypotension, shock, and arrhythmia. Again, it is an indication to start your anti-snake venom. oliguria, elevated creatinine and elevated CK. So that is again one more investigation that you need to set. So these will be the general indications to start your anti-snake venom. Now coming to the dose of anti-snake venom. So what is the recommended dose of anti-snake venom? That is again lot of queries. You need to start with 6 to 10 vials. So our idea is to neutralize as early as possible. So we are not giving like 2 vials daily. We want whatever dose you are planning to give as a, do not wait further. So whatever dose you wanted to give immediately to the patient. So initially you can start with, you have decided one of the indication is the 6 to 10 vials you start off with. Then there are 6 to 10 vials of ASV, and maximum dose that you can go maybe is 25 to 30 vials. Why? The maximum amount of venom is injected by a Russell's viper. So this is the reason why I am discussing this. So Russell's viper, approximately the maximum animal study what they have found is somewhere around 143 mg is what is being injected from a Russell's viper. On an average, it gives you around 63 mg. So on an average, Russell's viper inject around 63 mg. So 1 ml of your anti-snake venom will neutralize 0.6 mg of Russell's viper venom. So on an average, you see, for to neutralize 63 mg, you need approximately 10 vials. So that is why I am saying 10 vials should be the starting. So the maximum venom injected is by Russell's viper. So the rest, cobra, it is 0.6 again. Then you have crate 0.4, 0.4. So these are the neutralization for the cobra, crate and saw scale viper. So the maximum amount of venom injected will be by Russell's viper. So if you give 10 vials, it will neutralize almost 63 mg. That is the average amount. And maximum, you see, 140 to neutralize 143. If you give 30 vials itself, it will neutralize 180 mg. So not more than 30 vials. So that is the reason why I am saying more will be 30 vials. But there are issues now. There can be a chance of resistance. And what venom you are preparing is only from one geographical area. So there is a huge chance of resistance to this anti-snake venom that has been reported in multiple areas. But in general policy, you remember 25 to 30 vials is more than enough. And when you want, if still the patient is having bleeding manifestation, then you need to think of giving other blood products. So that is what you need to remember. So that is the dosing of how much dose that you need to give, minimum and maximum dose that I have said. And there is no test dose. No test dose. Remember, there is no test dose. Anaphylaxis can be a potential risk. So just treat when anaphylaxis comes. And if the patient is having a higher risk of developing anaphylaxis, you give them pre-medicate with adrenaline 0.5 mg or 0.3 mg of adrenaline. That is the only thing. And further repeated doses. How to decide further repeated doses? Suppose you are given 10 vials of anti-snake venom. So you have to give further doses of anti-snake venom. How will you decide on it? So that is the next question. So once you give this anti-snake venom, you decided that one of the indication was there, you gave 10 vials. So 10 vials of ASV, the dosing, how you will give this ASV, you can give at a rate of 1 to 2 ml per minute. So there are two methods. You can take the whole anti-snake venom and you can put it in an infusion pump like this, and you can give it as a drip of 1 to 2 ml per minute. So approximately you are giving 100 ml, it will be over by 100 minutes. Or else what you can do, you can take your drip set, you can take your 5% dextrose or normal saline, you add this to this, ideally it will be normal saline, then you connect to the drip set and you give it as an infusion. But the whole this 500 ml should be over by 100 minutes. So you can have direct injection and you can have an infusion protocol also. Whichever is this, you can practice. But what we practice is much more easier. Take the whole ASV into a syringe and you give it a rate of 1 to 2 ml per minute. Suppose you are given 100 ml of anti-snake venom or 10 vials of anti-snake venom, so it will be over by 100 minutes. So when you will you decide, okay, this patient needs more dose of anti-snake venom. So there are two things that you can keep in mind. You completed the dose of anti-snake venom within 2 hours, that is 100 minutes approximately. Still the patient has features of neurotoxicity, still there is external bleeding that is visible, do not wait. You give another 10 to 20 vials. So the maximum dose you can give as early as possible itself. But when you have given the anti-snake venom, the patient has settled down, you don't repeat any investigation for the next 4 to 6 hours. After 4 to 6 hours, you repeat your coagulation profile because liver takes some more time to develop these coagulation factors. So you are given your ASV, suppose you have started your ASV at 8 a.m. and you have finished at 9:40 p.m. So what you have to wait is that you wait till somewhere around 1 p.m. and then you repeat 1 to 2 p.m. you repeat your PTINR and you see what is happening. If the PTINR is still elevated, you can think of giving further dose of ASV. If PTINR is normalized, no need of further doses of anti-snake venom. So that is what you need to remember. Suppose by 10:30 itself, the patient is having still neurological manifestation. So do not wait. You give further dose of anti-snake venom there itself. But if the patient doesn't have any of this, you can wait till 1 to 2 p.m. and repeat the PTNR and see what is happening to that. So that is just the timeline that I have given to you. So other management, neurotoxic envenomation. So this is regarding your anti-snake venom. Neurotoxicity, you need to give your neostigmine as well as atropine. So you can give approximately 1 ml of atropine. You pre-treat the patient with atropine because it can cause bradycardia. Neostigmine can cause bradycardia. Then you give 1 to 2 mg of neostigmine and you see further response. And maybe you need to ventilate the patient depending upon the respiratory paralysis. And regarding blood products, FFP cryoprecipitate, as I told, you are given the maximum dose of ASV, but still there is coagulation abnormality. You can think of giving your FFP cryo as general you manage for any of this DIC. For organ support, remember regarding dialysis, inotropic medication and ventilatory support, these things that you need to be remembering in for all patients. And all patients require a tetanus prophylaxis and an antibiotic, maybe to start off with a penicillin, augmentin, and depending upon the this thing, you have to keep the compartment syndrome also in your mind. There is already few lectures regarding snake bite, which we have discussed all those things in detail. So this being a rapid revision, I am not going to all those things. So there can be long-term complication. There can be tissue loss, infection, osteomyelitis, contracture, hypertrophy, keloid scars, CKD, chronic panhypopituitarism, psychological morbidity, post-traumatic stress disorders. This all can be a possibility. So that is what all about snake envenomation. It's a rapid revision because it has taken a longer time. But just remember that you treat the patient as per the clinical symptoms and you see whether there is any indication to give your anti-snake venom is there or not. Thank you.